Hi everyone, I'm Amanda Olson and I'm a doctor of physical therapy and certified pelvic floor rehabilitation specialist, and welcome to our webinar on how to train proprioception in the pelvic floor without training gripping or hypertonicity. So I'm going to switch over to my slides here and we'll get started. So we're going to talk about how to train proprioception and awareness of the pelvic floor and improved activation without causing gripping, hypertonicity, or motor control problems, which I know is a major concern for a lot of us in our practice. So I'm going to teach you this by showing you how to use resistance training with functional activity movements in order to improve pelvic floor strength for urinary incontinence or pelvic organ prolapse, and how to address soft tissue restriction first. So a little about me. I am the product development and creator of the educational materials here at Intimate Rose. I am certified in pelvic floor rehabilitation by both the American Physical Therapy Association section on women's health and by the Herman and Wallace Pelvic Institute. I'm also a STOT Pilates instructor, and just for fun, I'm also a certified running coach. So what we're going to learn during this presentation is how to train pelvic floor with resistance so you can help your patients reach their goals, how to create shorter home programs so that the patients will actually do them and be compliant, and a new way to think about training proprioception without training gripping so that you can get your patients back on track. Okay, so the traditional pelvic floor training usually includes educating our patients in breathing, providing manual therapy in places where it's warranted. So for example, if they've got a tight rib cage and their diaphragm is restricted, or their obliques are restricted, or they have scar tissue and trigger points in their abdomen or in their pelvic floor, we certainly want to address those first prior to instigating Kegels. It is entirely possible for a woman to come in with urinary incontinence or pelvic organ prolapse, these diagnoses that traditionally fall under that low tone or weak pelvic floor muscle paradigm, and for them to have trigger points in there that are getting in their way of being able to properly contract the muscles. Also, by doing the manual therapy first, we have the opportunity to start to integrate some neuroplasticity into our treatments. So, strain, counter strain techniques, soft tissue massage, myofascial release, whatever you're comfortable with, joint mobilizations where it's warranted in the pelvis, helping them to have a better foundation before we go about strengthening them is going to put them with best foot forward. So whatever your skill set is, use it. I happen to enjoy using strain counter strain through the abdomen and the pelvic floor to address trigger points. I also do myofascial release and skin rolling. I also do visceral mobilization where it's warranted, where I find areas that are restricted. And then I teach them Kegels, and I teach them usually on day one if there's not too much soft tissue restriction. But if there's a lot and their proprioception is poor, I'll wait and go over it in future visits. Certainly, biofeedback is an amazing and valuable tool if your clinic can afford it. There's a lot of different forms of visual biofeedback. I work in a clinic where I have real-time ultrasound, and I love it, and I use it for visual biofeedback, but I don't tend to use internal sensors and software programs a lot. We have it available, it's just not part of my practice program, but if you've got it, use it. Those are all really wonderful. But additionally, using vaginal weights is one way to get that carryover from your session to home, because sometimes we find ourselves giving really great cues and the patient really seems to be grasping the motor control of how to activate their pelvic floor, and they go away and they come back next week and it's gone. And the carryover just didn't quite happen. So we'll talk more about that to come. So when I was analyzing my practice, I've been in pelvic practice for almost a decade. And what I was finding is that when I was doing the regular kind of proprioceptive training using the biofeedback devices, it was taking weeks, if not months, to set in. And that was for a variety of different tones. Sometimes we get people that just have those coordination issues and the carryover is not sinking in. And we can send that biofeedback machine home and hope it comes back, or hope they use it and hope they're training properly. Sometimes those sensors are responding to other things in their home, like light, or sometimes I've seen where the device will activate even if they're bearing down. So the device is then reinforcing the wrong activation pattern, and it's not sensitive enough to pick up on a contract and lift versus a contract with bear down. And I was also finding that it was fixing my patients for their day-to-day tasks with light activity, but if they were wanting to do something more exertional, they were still incontinent. Insurance changes we've talked about. So just again to reiterate, we're seeing a time where there are high deductibles. Sometimes patients have no insurance, or they're only being allowed a few visits, and we don't have time to take them through 12 weeks of a motor training protocol. So how do we do better? I decided to study the actual techniques of my orthopedic counterparts. It's really interesting in pelvic floor. Sometimes we forget about our orthopedic skill sets, where if a patient came in with a torn rotator cuff, we would be eventually progressing them through a resistance exercise program of their shoulder rotator cuff muscles, right? We would give them TheraBand exercises. They would have some closed chain and some open chain strengthening maneuvers. And those same principles can and should apply to the pelvic floor, especially when we are considering the patient-centered goals. So if this is a person that is obese and they are going to be carrying around a higher mass of trunk over their bladder and over that pelvic floor, then their pelvic floor is going to need to be trained in a way that can help them withstand that weight problem. Certainly, hopefully we're doing them the service of discussing some of the lifestyle factors that are contributing to their incontinence, like diet and bladder, and bladder irritants related to diet, and some of the lifestyle factors there. But at the end of the day, too, we need to get their body in a position to be able to tolerate what they are needing from it. So one other thing is that rarely do our orthopedic PTs tell patients that their goals are unattainable unless they are really, they really are not appropriate for that body. So I just wanted to reiterate that point of that. Just because you don't believe that long distance running or maybe CrossFit or some other forms of exercise are a legitimate form of movement, or you don't agree with it, does not mean that we should be recommending against that for a patient without really looking at if their body can. And again, certainly there is a place for a pessary. I just reiterate this because my mom, for example, is a really small lady, and she has worked since she was 18 years old unloading trucks. So my mom unloads semi-trucks at her work all day long, and she has since she was 18 years old. She's had 2 babies, and if she was to go into physical therapy for her pelvic floor and somebody were to say, well, your body just cannot tolerate you lifting 100-pound boxes all day long, day in, day out, well, my mother would be walking out of the door, right? So we want to be able to support our patients where they are and provide them with the background they need to make a good decision. So 3 pillars to improve pelvic floor training, again, include breathing, coordination of the pelvic floor in conjunction with that breath and in conjunction with other movement, and then resistance with functional movement. So breathing, whereas the pelvic floor is the floor, the diaphragm is the ceiling. So we want to assess rib cage mobility laterally and in the anterior posterior direction. We want to watch how they're breathing to see if it's belly dominant versus chest dominant or balanced, assessing the spring ability of the rib cage itself, checking for trigger points in the diaphragm and in the obliques, the rectus abdominis as well, and checking for the tone of the obliques. Something that I've noticed in my clinical practice is that a lot of patients will grip chronically in through their obliques to help try to stabilize their trunk and their pelvis, and they are breathing really high in the into the chest. They're breathing through the sternum, gripping through the obliques, really tight rib cage, and we can imagine, knowing what we know about pressure in the thoracic cavity, of what that's doing. So I like to spend a really significant amount of quality time with my patients talking about why breathing is important and why we want to breathe in that inhale, relax, exhale, contract pattern when we are starting to move into the strengthening phase of pelvic floor. For soft tissue restrictions, I utilize strain counter strain for trigger points in the diaphragm and the pelvic floor. I do scar mobilization in the abdomen and the thorax, and some visceral mobilization when I deem it to be necessary. Coordination. We want to educate our patients that they are relearning timing and coordination of the pelvic floor muscles versus using strength. I know I have said that word in this webinar, but I don't tend to use weak versus strength in the clinic because of how it feels to our patients. Sometimes when we say, oh goodness, yeah, you're leaking and it's because you're weak, that can invite a certain feeling into our patients. And it's not that we want to be dishonest or anything, but sometimes too, we've noticed that just improving that coordination between the breath and maybe cueing the anterior fibers of the pelvic floor, they instantly become stronger in that one session. You know, they did not become stronger, they just improved their coordination so they were able to activate the pelvic floor better. And so I tend to use that paradigm with my patients more than the strength versus weakness phrasing. When I'm cueing the Kegels, I like to cue the urethra as a telescope for urinary incontinence. I have found when I watch my patients on ultrasound imaging and when I palpate it myself during internal examination, that they are activating the anterior fibers of that pelvic floor and isolating them much better when we draw their attention to the urethra. For some patients, that cue is not the best one, and treat the patient in front of you. You keep working until you find the cue that elicits the behavior that we want to see. I've also had some good luck with marble at the base of the vagina for prolapse. So whereas they are trying to pull that marble into the vagina and up, sometimes using it as like a pinball machine. I have not had the best luck with the elevator, but maybe that is just me. Again, training options for motor control include biofeedback, real-time ultrasound, and vaginal weights. So vaginal weights as a proprioceptive tool, again, was an idea that came about in the early 1980s. And what I have found is that body positioning is key. So when we're looking at the fact that women have different sized vaginal vaults and prolapses may be in the anterior aspect versus the posterior, depending on if they have a rectocele versus a cystocele versus enterocele. So I like to position my patients when they first start out according to where their greatest need for input is. So this could be in prone or quadruped for a patient that is experiencing urinary incontinence and is having a really hard time activating those anterior fibers. So when we think about that, here's our pelvic model, organs coming out. If they are experiencing difficulty activating anterior fibers here, I'll have them put the vaginal weight in, just like a tampon, and have them either lie down prone with the pillow under their abdomen or be in quadruped. What that does is the vaginal weight is going to tip forward and put more pressure onto the anterior fibers of the pelvic floor, thus drawing their attention to it. And I have them either stay there statically for a few minutes, 5 to 8 minutes, and just practice that way, or they can practice doing a Kegel in that position. So they are not moving against gravity in that particular paradigm with the whole pelvic floor, only with the anterior fibers. So they are getting the added benefit of that resistance there. And additionally, they are able to identify and feel where that weight is. So they know that they are getting it. You can also have them seated. Seated is going to have them in a stationary position where they're getting reinforcement from the surface that they are sitting on. And I find that that is really beneficial for my patients. Once they can activate and sense the muscles in this progression of movements, they can move to supine or standing, or they can be moved upright against gravity in the standing position with a variety of different movements that they would do on a day-to-day basis. So for example, putting the weight in and taking a shower. Want to keep that time parameter around 8 to 10 minutes so that we do avoid overworking the muscles, but that's a good time parameter to train endurance of the muscles, which is important for conditions like pelvic organ prolapse, where we want to have those muscles learn how to activate in a more sustained fashion for stabilizing and protecting that pelvic floor and the organs that it supports during heavy activity. So then we can move on to resistance with functional movement. And that positional progression, as we discussed, will be moving from seated to standing, and then standing with functional movements. And we are focusing then on endurance, power, and coordination of the muscles. I like to train them for 8 to 10 minutes additionally. If your patient is tolerating it well, they can maintain for 10 to 15 minutes at a time, only once per day, allowing for proper rest of the muscles. And they can also be doing active Kegels with them too. And you can alternate A day and B days. So A days working on endurance, B days working on more power. To train power, you'll want to do either seated or standing Kegels where they're going to put the vaginal weight in. They'll contract and hold 3 to 5 seconds for 10 reps, 3 times a day. If they are incontinent, I highly recommend upping that number. Though it's really interesting, the literature supports 8 to 10 sets of 10 Kegels per day, so 80 to 100 Kegels to get a patient dry. But when we add resistance, we are working the muscles significantly harder. And so that number can be brought down a lot. And so that's too where we have the opportunity to elicit a strengthening program that can get our patient stronger, faster, or with more motor control faster. Standing functional movements. These are a group of exercises, and you'll find it on that home exercise PDF that we've created for you. I group them together to address stability of the pelvis and the lower extremity and the trunk in conjunction with the pelvic floor. So I have my patient put the weight in and do a set of 10 heel raises, and then a set of marching where they are doing reciprocal movements, so it will be a right-left march, and then lateral hip abduction or side kicks. I have my patients only abduct 8 inches, and I have them really focus on keeping the foot and knee in alignment with the hip. And then a mini squat where they are focused on pressing the hips back as if they were going to sit into a chair and then coming back up with the weight in. That's a naturally opening maneuver of the pelvis where the pelvic floor wants to be able to relax. And we are training the pelvic floor to be able to stay contracted and withstand that for protection against leakage when they're in transitional motions like sit to stand. And then I have them do an actual sit to stand. So with the weight in, sit down, and then they will stand up. They're going to want to initially think about a little extra contraction around that weight to secure it in as they're doing that sit to stand motion. They can also put in the weight and put it into the shower. The reason why I love the shower is it combines all these multimodal movements. So bending, flexing, you've got upper extremity motion to reach up and wash the hair, bending over to clean the feet and shave the legs maybe. But it's just a really nice variety of movement. So the Intimate Rose Kegel exercise weights range from 25 grams to 125 grams. They are progressively stepped up as the color purple intensifies, so does the weight. So the implications of this for pelvic floor practitioners, so as I've just shown you, this is the progression of exercises that I take my patients through, whether they are seeing me in clinic or they are somebody that cannot attend clinic or only has a few visits under their belt to see me. If you ever have any questions about how I implement this or how you might go about doing it in your practice with a specific patient population, I would be delighted to help you. You can email me at amanda@intimaterose.com, and we've provided the download to the free home exercise program to use at your discretion. So this system is specifically designed to train proprioception for any level of strength, build coordination using functional activities to mimic daily life challenges our patients face. And we are doing this to achieve our patient-centered goals. So we are helping them to be able to withstand the high pressures that their body may be facing throughout their day for their jobs and hobbies and lifestyle. Implementing this into your clinic can look very similarly. So screen and treat your patients for breathing and coordination issues, and then implement progressive resistive training so that you can help your patients achieve their goals faster. And the vaginal weights are a tool. You know, they're not meant to replace us as pelvic healthcare providers, though they certainly can be a stand-in for basic urinary incontinence or prolapse if our patients don't have access to us. And so we can still be helping them. You know, sometimes too, I live in an area where I have patients that drive 2 hours to see me because though I live in a city, I'm surrounded by a very rural population. And during the winter, they cannot drive over mountain passes to see me regularly for their appointments. So I have found that this is a really excellent tool to help progress them during those times and with weather related, whatever, where they can help get themselves better. If you are interested in ordering, you can do so for wholesale at support@intimaterose.com. You can also direct your patients individually to order direct off our website, www.intimaterose.com. It would ship directly to their house. No prescription is necessary. Our shipping is very discreet, and we have excellent customer service that's very compassionate and works really well both with providers and with patients. So that is all for today. I really appreciate you being here and watching the webinar. If you have any questions, again, please don't hesitate to email me at amanda@intimaterose.com, or you can contact our customer support at support@intimaterose.com. And I look forward to hearing your feedback. Have a good day.